Okay, so this is the question that we are going to discuss now. So this is what we have discussing about the gout. So before the gout, we have discussed that this is the more common in males. And if we talk about the little bit about the biochemistry, so you know that we would be having the some nucleic acid. In the nucleic acid, it is made up of nucleic acid, and this nucleic acid, it is made up of what? That is the nucleotide plus ribose sugar plus pentose sugar. So they are made up of they are the polymer of what? They are the polymer of the nucleotide, and this nucleotide, they are made up of nucleosides plus there would be the nitrogenous base. Here if we talk about the nitrogenous bases, these are the two types. We have the purines and we would be having the pyrimidines. If we talk about the purines, we have the two type of the purines, that is known as the adenine, and we would be having the guanine, and the pyrimidine, if I say, that is made up of the thymine. So the three type of the pyrimidine: thymine, cytosine, and the uracil. So these are what? These are the three type of the pyrimidines. Thymine, it is present in the DNA, while the uracil, it is present in the RNA. Okay. If we talk about the purines like adenine and the guanine, these adenine and the guanine, they will undergo the purine salvage pathway. So here we are going to discuss about that is the adenine and guanine. The adenine and the guanine, what they will do? They will go for the phosphorylation, and they will make what? They will make the hypoxanthine. They will make what? They will make the hypoxanthine. This hypoxanthine will be converting into the xanthine, and this xanthine further will convert into the uric acid. This is the simplest pathway. Then this hypoxanthine again will be converting into, by some more reaction would be there with the help of HGPRT. That is known as the hypoxanthine phosphoribosyl transferase. Hypoxanthine phosphoribosyl transferase. Okay, so this is what? That is the adenine, that is guanine. So they will be converting into the hypoxanthine, and the hypoxanthine will be converting into the xanthine, and this will be with the help of enzyme that is known as the xanthine oxidase. And again here we would be having enzyme that is known as the xanthine oxidase. Okay, now there is a two enzymes. Remember, if we talk about there is a HGPRT, hypoxanthine phosphoribosyl transferase enzyme. So if this enzyme would be deficient, so this is known as the syndrome that is known as the Last-Nyhan syndrome. Last-Nyhan syndrome. Now tell me, if there would be the deficiency of HGPRT, so there would be the hypoxanthine would be more, and if hypoxanthine would be more, of course there would be the more xanthine, and if more xanthine means more uric acid would be there. So in the Last-Nyhan syndrome, you will see the hyperuricemia. What does it mean, hyperuricemia? Means there will be the increase of what? Uric acid. Uric acid. After that hyperuricemia, what you will see? The patient would be having the self-mutilation. There would be the self-mutilation would be there, and the patient would be having the mental retardation. The self-mutilation means person, like basically this is seen in the children. So the children will harm himself. He will harm ourselves. It means that the Last-Nyhan syndrome, the self-mutilation, you will see the child will be having the lip bite. Okay, he will bite his lips, he will bite his fingers or bite her fingers. So that is the self mutilation, and other than that you will see the mental retardation and the hyperuricemia. Now you are seeing here that hypoxanthine would be converting into the xanthine, and here we would be having the uric acid. The enzyme here is here, that is the adenosine deaminase. The adenosine deaminase. Okay, so if I say that if there is a xanthine oxidase, if this xanthine oxidase would be there, if we will inhibit this xanthine oxidase, so we can decrease the uric acid formation. And if we would be having the increased amount of the uric acid, for example, if we would be having the more xanthine oxidase, more purine metabolism would be there, so there will be the increased amount of what? Uric acid. And the increased amount of the uric acid, this is known as the gout. Okay, so now let's study about the gout. So gout is what here, that we have seen that this is what? The metabolic. What is the metabolic? Metabolic means there will be the anabolism, catabolism means breakdown or synthesis of something. So that is known as the metabolism. So this is what, that gout is what? That is the metabolic disease. This is the metabolic disease, and this is characterized by deposition of something, the deposition of monosodium urate crystal, means these are the monosodium urate crystal, means the crystal of the uric acid, the crystals of the uric acid. So monosodium urate crystal would be deposited. Where it will deposited? In joints and connective tissue. In joints and connective tissue. In joints and connective tissue. So this is known as the gout. And we have discussed that this is the more common in males or females. It is more common in, of course, males. It is more common in the males. If we talk about there is a gout condition. So gout, it can be the acute gout or it can be the chronic gout. Means acute gout means it is very early disorder, means within the 3 months. So if it is the acute gout, in acute gout you will see the patient would be have red, hot, swollen joint. The joints would be swelling. There would be the redness. There would be the patient will be feeling hot to touch. Okay, so that is the red, hot, swollen joint will be there. And if you want to do the examination, so there would be the extremely tender on examination. There will be extremely tender on examination. The extremely tender on the examination. And this is what? This is the most common joint. If we talk about in acute gout, the most common joint that is affected is what? That is metacarpophalangeal joint. The most common joint affected in acute gout is the metacarpophalangeal joint. Metacarpophalangeal joint would be affected. Okay, that is the MCP. So MCP joint would be affected. So what we have discussed in the acute gout, the patient will feel the red, hot, swollen joint would be there, and if you do the examination, there will be the extremely tenderness. Tenderness means some like hardness would be there. The hardness of the joint would be there, that is known as the tenderness. And the most common joint affected in the acute gout, that is the metacarpophalangeal joint, that is the MCP joint. So what you will see in the acute gout, there will be the synovial fluids. Of course, whenever we talk about our knee joint, our hip joint, so they all are the synovial joint. They all are our synovial joint. And in the synovial joint means they would be having some synovial fluids. Synovial fluid means they will be having the movement. They will help in the movement. Okay, so we would be having like our elbow joint, wrist joint, our knee joint, our shoulder joint, our hip joint. So they all are the synovial joints, in which we will see there will be some movement would be there. So what you will see here, that all the joints would be affected. Like we are seeing here, the most common joint is the metacarpophalangeal joint. For example, in this we would be having the synovial fluid would be there. So what you will see in the synovial fluids, in the synovial fluids you will see there will be the increase of what, leukocyte count. The increase of the leukocyte count would be there. Means leukocytes are what? The leukocytes are the WBC, and the WBC we would be having the neutrophils, eosinophils, monocytes, lymphocytes and the basophils. So increased leukocyte count would be there. Along with that, which leukocyte would be more? That is the neutrophilic leukocytic. That is neutrophilic leukocytosis. We know that is also increase in which condition? Bacterial conditions. Okay, so you will see the neutrophilic predominance. So the patient, how the patient will come? The patient will come like, doctor, I have the problem, I have the red hot swollen joint, I have the joint that is swelling, that and it's red and feeling very very hot to touch. Okay, after that you will see the examination, you will do the some test and you will see there is some neutrophils is increasing. After that, if you will talk about do the microscopy, what you will see on the microscopy of the synovial fluid, you will see there is a negative, there will be the negative birefringent crystals, where you will do the polarized light microscopy, on polarized light microscopy. And this is very 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 important point. If you will do the polarized light microscopy of the synovial fluid, you will see there will be the negative birefringent crystals would be there. Okay, so this what you will see on the in acute gout in synovial fluid. After that, if you will say that there is a patient with the chronic gout, so how the patient will, the chronic gout will be present to you? The chronic gout patient would be having the tophy would be there. Means they would be having the tophy. What is this tophy? That is this tophy. These tophy are what? These are the some nodule structure. These are the nodule structures would be there. So what you will hear, their patient either their nodules may have discharge. They either may have the discharge can be there. And if this, for example, if this tophy, they will become enlarged. They become enlarged. So what you will see, they will tend to calcify. They will tend to calcify. And what they will do? They will produce the symptoms. They will produce the symptoms. Okay, let's see what's the tophy. So you can check out check in the Google. So this is what we call, that is the tophy lumps. What are the tophy lumps? These are the tophy lumps. Check out the group. So here you can see that this patient has got the tophy. So what are these tophy? These are the nodular like structures. Sometimes what these nodules may can have the discharge also. So that's why that is the same things, and this is seen in which condition? Is seen in the chronic gout. This is seen in which condition? That is the chronic gout. And why these nodules would be there? Of course there will be the uric acid accumulation would be there. There would be the uric acid crystals would be there, that will be accumulated in this region, in this nodule. So that is what? That is the our nodule. That is what our nodule. Okay, so this is what that we having the chronic gout. In gout, remember, we would be having the some sign would be here. Sign you have to remember, that is the Martel sign. That is the Martel's sign. The Martel sign would be there, the G sign would be there, or you can see the rat bite erosion. Rat bite erosion. Rat bite erosion. So this is what we will see in the gout. In the gout we would be having the Martel sign, G sign, and the rat bite erosions would be there. Okay, let's see what is the Martel sign. Okay, so this is what that you are seeing on the X-ray, so that you will see the Martel sign. Okay, so this is the known as the, sometimes this G sign or the Martel sign, or you can say the Martel sign, or we call this as the G sign, or we call this as the, you can see here that it looks like the what, rat bite erosion. It looks like the rat bite erosion. So this is what, that is the Martel sign or the G sign or the rat bite erosion that you will see in case of the gout. Okay, is this clear? There is a one more conditions that is known as the pseudo gout. That is known as the pseudo gout. Pseudo gout. If we talk about the pseudo gout, the most common joint here the involved is the knee joint. The most common joint affected here, that is the knee joint. The knee joint that is commonly affected. But here if we talk about in the pseudo gout, there will be the deposition would be different. What would be deposit here? That is the calcium pyrophosphate. There will be the calcium pyrophosphate. This would be deposited in case of the calcium pyrophosphate will be deposited where in pseudo gout. The calcium pyrophosphate would be deposited where in pseudo gout. In pseudo gout, what will be affected? With what would be deposited? So that is the calcium pyrophosphate would be deposited. Okay, is this clear? So what you will see in the gout? In the gout, we will see the deposition of the monosodium urate crystals. While if we talk about the pseudo gout, remember there will be the calcium pyrophosphate that would be deposited, and that is again very very important that you have to remember. Sometimes they give you the, this is a very direct question that will be coming in your exam, so that you have to remember very importantly. Okay. If you want to write the difference also of the gout and pseudo gout, so you can write it here. Write the gout and pseudo gout. In gout, you will see there will be the deposition of the monosodium urate crystals. There will be the deposition of the monosodium urate crystal would be there. Monosodium urate crystals. While in the pseudo gout, remember we have just talked that is the calcium pyrophosphate. See, sometimes they write the CPP also. Calcium pyrophosphate. So that is, you can write CPP, calcium pyrophosphate. What is the shape of these crystals? The shape of these crystals, they are the, like we would be having the needle like shape. These are the needle like shape crystals. These are the needle like shape. And these are the rhomboid shape crystals. These are the rhomboid shape crystals would be there. If we talk about the, that we have discussed here, that on the polarized microscopy, how it will be given? There will be the Bayer fringens pattern would be negative. So they have the negative Bayer fringens pattern. And if we talk about the pseudo gout would be weak positive. The pseudo gout will give the weak positive Bayer fringens pattern. And which joint I told here? The joint that is the first, basically metatarso, here the first metacarpal, wait, I told what? Sorry, please make it correct.
Metatarsal.
I wrote the metacarpophalangeal. No. So this is what? That is the metatarso. That is the metatarso-phalangeal joint. That is the MTP. Okay, that is the first metatarsal basically. So that is the first metatarso. The image I also send you. The image, if you will see that here also you will see there will be the which joint would be affected, that is the metatarsophalangeal joint. You can see that the first metatarsophalangeal joint would be affected in case of the gout. That is the first metatarsophalangeal joint, and here which joint would be affected? That is the knee joint would be affected. Okay, on X-ray what you will see? On the X-ray you see there will be the rat bite erosion. You will see the rat bite erosion would be there. And here you will see the chondrocalcinosis, means the cartilage would be become calcified. So that is the chondrocalcinosis would be there. Okay, is this clear? So this is what you have to remember, and everything you can clear about the gout and the pseudo gout. So gout, remember, monosodium urate crystals. Pseudo gout, you would be having the calcium pyrophosphate. These are what kind of the shape, needle like shape. They are the negative birefringence pattern, and they are the weak positive. And the joint affected is the first metatarsophalangeal joint. So please make the correction that in the gout we would be having the metatarsophalangeal joint. The note the MCP. Okay. Is this clear? If you wanted to show, see the. Okay, what I was asking? I was asking like what is the another name of the gout? Another name of the gout is what? That is known as the podagra. Okay, gout is also another name. The another name is what? That is known as the podagra. Podagra. So this is what? That is the another name of the gout. Okay, is this clear? So this is what we would be having about the gout. So now let's see the question. Here you are seeing there is intense pain is there, ankle joint area. So the ankle joint area basically we would be having near to the metatarsophalangeal joint, and you will see the temperature increase. So there will be of course the redness, the means temperature hot to touch would be there, and sudden onset of illness. There was a similar attack lasting 5 to 6 days, because this is what this the having the recurrent episodes would be, you will see. In case of the gout, you will see the recurrent episode. The patient will sometime will feel the okay, sometime will feel again when the person will doing so much work, so there will be again the inflammation would be rise. So that's why this is the recurrent, like the disease, recurrent disorders would be there. The skin over the joint is hyperemic without definitive borders, without infiltrative banks on the periphery. So what is the most likely diagnosis here? That is what? That is the gout. Other we have discussed already, that is the rheumatoid arthritis. That is the rheumatoid arthritis we have discussed. Residual changes. After that, if we talk about the next question that we have already done, then there is a question number 7. A patient has complained of the great weakness for the 6th year. Now you see the translation, the great weakness. What is the meaning of the great weakness? And he fell seriously ill. The illness is accompanied by the body temperature rise. There is indisposition, pain in the joints along the leg muscles, violet bluish erythema. So this is the main key point here. The violet bluish erythema around the eyes. So this is what? That is the one type of the rash, and we call this type of the rash is known as the heliotrope rash. This is known as the heliotrope rash. And over the knee joint also, that is the around known as the Gottran signs. So what will heart rate 120 per minute, heart sounds are weak, blood count, leukocytes are there, ESR is there. What is the most probable diagnosis? So all these rashes that we will see in case of the dermatomyositis. So let's see here about the dermatomyositis. And dermatomyositis is again very important topic. All these topics basically are very important. Maybe you will get around 4 to 5 questions from this topic itself. So write down the heading, that is the dermatomyositis. If we talk about the dermatomyositis, it is again that is the autoimmune conditions. It is what? That is the autoimmune condition. There is again the autoimmune condition would be there. There is a autoimmune conditions, and again this is autoimmune condition. So this is the autoimmune connective tissue disorder. The autoimmune condition, and it is what? It is the connective tissue disorder. In talk about the dermatomyositis, it comes into the broad category called the inflammatory muscle disease. This comes in the IMD. There is the example, that is the inflammatory muscle disease. The inflammatory muscle disease. So this inflammatory muscle disease, again this is the type of what, that is a connective tissue disorder, and this is what the autoimmune conditions, and it also involves the multi-system organs. It also involves the multi-system. So this is the autoimmune condition. So what I told, that most probably in the most of the cases the autoimmune condition, that female would be affected more than the male. So it will be around 2:1. It is the 2:1. Here the ratio is less, but again the female is affected more than the male. And also remember one important thing here, that you will see in the dermatomyositis, this is the autoimmune conditions. The cause I told, that all autoimmune conditions, they would be having some genetic factors would be there, and they would be having some environmental factors would be there. So this is what, this is the autoimmune, and this is the connective tissue disorder. Another important point you have to remember, they would be having the bimodal distribution. What is the bimodal distribution? It means that the two age group would be affected. It can be the juvenile, or it can be the like the juvenile dermatomyositis, or it can be the adult dermatomyositis. If we talk about the juvenile dermatomyositis, remember, means 5 to 15 years we are talking about. And here if you want to talk about the adults, so adult, remember, the 40 to 60 years they will be affected. So that's why we call this as the dermatomyositis. It is what, it is the bimodal distribution. It having the bimodal distribution would be there. And this is, as the name is suggesting, that is the dermato. So that is the derma, means skin would be removed, and matomyositis means muscles would, myo means muscles, derma means that is the skin. So skin and the muscles would be involved. So what it will involve? It involves the skin and the skeletal muscles. It involves the skin, like the derma, and the skeletal muscles would be involved. And in the skeletal muscles, basically you will see there will be the proximal muscles would be involved, means there will be the proximal weakness, proximal paralysis, everything related to the proximal muscles, and that's why we call the dermatomyositis at the proximal myopathy. Myopathy means we have the muscles, and the pathy means of course the pathology. So they are associated with the proximal myopathy or proximal muscles. So you will see the proximal muscles weakness would be there. Okay, is this clear till now? If we talk about the risk factor of the dermatomyositis, so we know that this is an autoimmune condition, and autoimmune condition we have discussed that there will be the some environmental role will be there, and there will be the some genetic role will be there. So if we talk about the some risk factors, there will be the risk factors would be there. So risk factors involved here, that is the genetic risk factor. There can be we would be having that is the environmental, and there would be the like some drugs are also there that would be also involved. Genetic factors, they are associated with the which gene? That is again HLA-DR-B103. देखो, if you don't able to remember the genetic or the genes, it's okay that you're not able to remember, but just remember that there is something like that HLA something DR3, some, just if you remember this thing also, that is more than enough. So just remember there was the HLA-DR-B103. In the first reads, if you able to understand this, that you know where the like what kind of the gene, HLA something, HLA DR, HLA doctor is something is there, it means you are on the right track. Okay, don't worry if you don't able to remember these type of the gene. Just remember, because we have to write something. If I just write the genetic, it means that you have to you should ask me what are the kind of the genes would be there. So just remember there will be the some gene would be there, HLA-DR gene. Okay, that you can remember. Just don't, if you don't want to remember the 03, no worries. Just remember the dermatomyositis. So dermatomyositis, 7 minus 3 is equals to 4. The D comes in the 4 terms. Like anything you have to just mug it up. Something. The remember things is never been remember for always. You have to remember, you have to revise them again and again. That's what you can remember for the long time. So if you're not able to remember, if you're not able to recall at the main time also, then still don't worry about that. You are on the right tracks. If you know something about what you have studied, that you have, if something is coming in your mind, okay, I have studied the anti double standard DS, DN, DNA, DNS, DNA, something in where, something in SLE. So it means that you are on the right. If you're not able to remember the full term also, you just remember the DS also, it means that you studied something. Okay, so it always been there. Whenever you will revise again and again, it will be on your lips. So don't worry about anything. Just whatever you are going through, you have to put your work hard in this final year, so that you will be a successful doctor in the nearest future. And believe me that after the once you will clear this whole 6 year, then there will be the less interest in the study also, and everything will become the less interested. So that's why give your best in this in this 6th year, and in your in this final year, so that you can gain as much as possible when during your study itself. And you will able to, at least in the end, you can say that okay, I remember something, I know something till now. And that's also the my main concerns, that you should remember in the end that okay, I know everything about the medicine. If somebody will ask me the some basic points, I know that thing. That's what I want from you all. Then we would be having the, let's come back to our study. So we would be having some environmental factors would be there, that is like the ultraviolet B rays would be there, and there will be some virus would be there, like the Coxsackie B virus, Cox B virus, and we would be having the parvovirus B19. And there is some drug also, like for example the chloroquine. The chloroquine is the drug for the, which one, which, just write me in the chat box, chloroquine is the drug for which condition. And we would be having the colchicine. We would be having the colchicine would be there, or sometimes the statins also would be there, that cause the dermatomyositis. So in the, we would be having the risk factors. We would be having the three risk factors. We have the genetic, we have the environmental, we have the drugs. HLA-DRB103, HLA-DRB107, ultraviolet B rays, Coxsackie B, and parvovirus B19. Then drugs like the chloroquine, statins, colchicine. So these all are the drugs that can cause the dermatomyositis. Okay. And what you have to remember, what are the risk factors? I think we have the, that is the malaria. So malaria is what, that is the correct one. So the chloroquine, it is the drugs that will given for the malaria. Then we have seen that there is a bimodal distribution. So we would be having the juvenile would be affected, and the adults like 40 to 60 years, and the juvenile like 5 to 15 years would be affected. And this is what, this is the subacute condition. So if you see here, there will be the bilateral symmetrical conditions. If you talk about the dermatomyositis, so it is the bilateral, means it will be on the both side, and it will be like the symmetrical. It will be the, have the symmetrical appearance, like the symmetry would be there. Along with that, you will see there will be the, it is a purely motor condition. It is the purely motor. It means there will be only the muscles involvement would be there. There will be the only and only motor will be affected. So muscles involvement of course would be there. And there will be the proximal muscles would be affected. Proximal muscles would be affected. And they will see there will be the weakness would be there, loads of weakness would be, the patient will be comes with the weakness. And the weakness will be like over weeks. If I talk about like the person on the first week, there will be some progressive motor weakness, means there will be some proximal muscles would be weak. After that, you will see that there will be the neck muscles would be involved. Then there will be the patient will be having the problem in the respiratory muscles also. So he will be having problem with the swallowing. So the weakness will be like the, if we talk about the progression of the weakness, so there would be the, firstly there will be the motor weakness would be there. The motor weakness, he will not able to pick up something. After that, you will see the patient would be having the neck muscles movement there will be the neck muscles movement would be there, and there after that there again it will progress to the dysphagia, means the problem in the swallowing, because the swallowing muscles will not able to work properly. After that there will be the involvement of the respiratory muscles would be there, and if the respiratory muscles would be involved, there will be the problem in the respiration also, and finally the patients can having the death as well because of the purging of what respiratory muscles. So this is the like the progressions, like firstly there is the motor weakness, the neck muscles, then dysphagia, respiratory muscles, and this will be going like the progressively. So this kind of the weakness you will see in the patient, and the patient will come like this only, that okay, doctor, I have the problem, in the starting I had the problem in my motor movement, and now I have the problem in my movement in the neck. Now I'm whenever I try to move my neck, there will be feeling pain. So the pain would be not so much significant in the dermatomyositis, but you will see there will be the some resistance would be there in the movement of the neck. Okay, and remember that there is one important point here, that which muscles group not involved in the dermatomyositis or the inflammatory muscles disease. Muscles group not involved in dermatomyositis, not involved in dermatomyositis, or we can say that in IMD also, that inflammatory muscles disease, which muscles would not involve, that is the extraocular muscles. Can we tell about the extraocular muscles? There will be the extraocular muscles or the facial muscles. Extraocular and the facial muscles would not be involved in dermatomyositis or any inflammatory muscle disease. Okay, can we revise it with me? There is a muscles group that is not involved in the IMD, that is the extraocular muscles, and we have the facial muscles that would be not involved. Okay. Around, if we talk about the like around this in dermatomyositis, around 60% we have the painless condition. The either symmetrical you will see proximal weakness would be there, and 30% you will see the painless pain condition, and the patient would be having the weakness. So this weakness and the pain, the weakness, and you can write here the pain. So this is around in approx 30% people. In the 30% people you will see the weakness. In most of the condition you will see around 60% cases you will see that there will be the some proximal muscles weakness would be there, the purely motor, and remaining 10% it will be again the not seen. Like of course there will be some chronic conditions would be there, that is a different thing. So but here around 30% you will see the pain. So that's why I'm saying the pain is not so much significant in dermatomyositis. Okay, is this clear? Then what is the important point in you have to remember in the dermatomyositis, that is the skin manifestation, the skin involvement or the skin lesions. The skin lesions again they are very important one. Like for example, the first thing that you will see here, that is the Gotran's papules. Firstly I will write everything, all the skin lesions. I will discuss all the skin lesions. After that I will share you the image. So these are known as the Gotran's papules. These are known as the Gotran's papules. If we talk about the Gotran's papules, the Gotran papules, it is what? Or first you want to see the image. Let's see the image first. Okay, let's go through like that. Gotran's papules would be there. So Gotran papules, they are the erythematous, they are the scaly. They are the scaly. Erythematous means there is the redness would be there, and the flat topped. Erythematous flat topped violaceous papules means violet color papules. The violet color papules or plaque would be there. Violet color papules or plaque. So that is what? That is known as the Gotran's papules or the Gotran's plaque. And remember that which is the where it will present, it is present mainly on the dorsal surface of metacarpophalangeal joint, proximal interphalangeal joint and the dorsal interphalangeal joint. They present at the dorsal surface of the MCP, PIP and the DIP, and we would be having the that is seen in around like 30 to 40% of the cases. Now if you want to see the Gotran's papules, after that we would be having the, let's come back here. I hope you are able to see the image. So after that you can see that the second one we would be having, you can see that the heliotrope ras, that is the heliotrope ras would be there. That is the heliotrope ras would be there. And in the heliotrope ras, remember, you will see the violaceous periorbital edema, means violet color. Violaceous means violet color would be there. Violet color, violet like. The violet like would be there. Violaceous periorbital edema would be there, and erythema. And erythema means redness would be there. After that, the third one that you are going to see here, that is the Gotran signs. That is the Gotran ras or the Gotran sign. There is a two things. The one we are having the Gotran papules, and another we would be having the Gotran ras or the Gotran sign. Gotran's ras and Gotran sign. Gotran ras or the Gotran sign. This is also known as the linear erythema. This is also known as linear erythema. And this is like the we can say the linear erythema or the macular erythema, or where you will see this type of the erythema. This erythema will be seen over the Gotran papules, and we call this erythema is known as the Gotran ras, where you will see that typically where on the extensor surface, as we have seen there is on the MCP, PIP and the DIP. So they typically on the extensor surface you will see this kind of the ras, and these are of course they are the photosensitive. Then the next sign that we are going to see here, that is the V sign. And the V sign, where you will see the V sign, you will see the V sign on the chest. This is located over the chest. Then you are going to see here about the soul sign. The soul sign, it is present posteriorly over the back. So that is the soul sign. Then if we talk about the next one, that is the over the scalp, you will see the pruritic lesions. Over the scalp you see the pruritic lesion. So the scalp will also be involved. And along with that, what you will see, the telangiectasia. The telangiectasia means blood vessels would be there. The inflammations of the short blood vessels would be there, and you will see the periungual erythema would be there. Periungual erythema means like around the nails you will see there will be the some redness would be there. And another sign, the important one, that is the Halster sign. The Halster sign, it is what seen on the lateral aspect of the thigh. If you see one sign or the one rashes would be there, so that is known as the Halster sign. Halster sign. And there is a one more thing that you will going to see here, that is known as the calcinosis cutis. And this calcinosis cutis is also seen in one condition that we are going to discuss, that is the crest syndrome. So calcinosis cutis, this is that you will seen, and basically this is seen in case of the juvenile dermatomyositis. What you will see, that in calcinosis cutis means fingers, little fingers would be there, that will be calcified, and that we call the juvenile, that will seen in the juvenile dermatomyositis. And remember that this is also seen in which one condition, that is known as the crest syndrome. They also seen in crest syndrome, or we call the localized systemic sclerosis. Okay, that we will discuss later on. So that is also seen in the crash syndrome. Now let's see the image one by one. Okay, now see that this is what this is known as this one. So this one is what this one is known as the Gotran's papules. So this one is, you can see here, so this is what, that is the Gotran's papules that you are going to see. So these are known as the Gotran's papules. So these are the Gotran's papules where on the MCP, on the PIP and the DIP. Then after that, if we say that this one, what you will say, this one, so this is what, that is the linear arrhythmia. This is what, that is the linear arrhythmia. Okay, basically this is present on the Gotran's papules, but sometimes this can also present on the extensor surface also. So on the extensor surface, what you are seeing here, that is known as the linear arrhythmia. After that, if you are wanted to see this condition, so this is known as the, this one is known as, which kind of the rash is shown in the image. So this is known as the heliotrope rash. So this is known as the heliotrope rash. So they are the, you can see the periorbital edema is there, the around the orbit you can see there is some edema would be there, and it looks like the violet bluish. Here if you are, I don't know if you are able to see, but if you can see here that this looking like the violet bluish color here. This is a violet bluish arrhythmia. So that's why violaceous arrhythmia we will call it. What is this? This one, this is present where on the extensor surface. So what we call this condition? So again, these are again there is a Gotran's rash would be there. These are the Gotran's rash would be there. Sometimes they can also present on the knee joint. What is this sign? This sign is known as the V sign. This sign is known as the V sign. Uh, it looks like the V. Okay, so that what we will see, where we will see the V sign will be present on the anterior chest. The V sign will be present on the anterior chest. And don't confuse with V sign with, don't confuse V sign with this one. So this is what, this is the necklace appearance. This is what they both are the necklace appearance. So don't confuse with the V sign. The V sign you can see that is the looking hyperemic, yani ki redness would be there. But if you talk about the this another one, that is the necklace sign. So this necklace sign we will see in which vitamin deficiency, which vitamin B3 deficiency or the niacin deficiency. So this one is what, that is the vitamin B3 deficiency or the dermatitis that we call the necklace appearance, and this one is known as the V sign that we will see in the dermatomyositis. After that, you can see this sign. So this sign is known as the, this sign is known as the soul sign. This sign is known as the soul sign. Okay, that is seen on the back, on the posterior surface of the neck. And again this sign, what we call, these are again, that's the Gotran's papules, and above the Gotran's papules you are seeing the linear arrhythmia. Dekho, this one if I say, the two cell, see this one is on the left side you are seeing there is a rashes, and on the right side you are seeing some papules would be there. So above those papules you will see there is some redness would be there, linear arrhythmia would be there. So we call this as the Gotran's rash, or that is linear arrhythmia, and here we are seeing that is the Gotran's papules would be there. Okay, this sign we have discussed. What is this sign? On the lateral aspect of the thigh. So on the lateral aspect of the thigh, if we are going to see something, so this is what, that is the lateral aspect of the thigh. What is that? That is known as the holster sign. That is known as the holster sign. So this one is known as our holster sign. What is this? So this is, you can see there is a something like the calcification, which the name is also written there, that is the calcinosis cutis. So this is known as the calcinosis cutis, and this calcinosis cutis, this is seen in both crash syndrome and the juvenile dermatomyositis. Okay, all these images I will share you in the WhatsApp group, so you can download it from there. Okay, so this is what we have about our Everything is clear now. So this is the dermatomyositis. So you can see here that we would be having the violet bluish erythema around the eye. So what is that rash? Heliotrope rash over the knee joints. That is the we can see the Gotran rashes would be there. So that is seen in the dermatomyositis. Then the next question, if we say that a 31-year-old patient has been suffering from the systemic scleroderma. So systemic scleroderma, we will going to discuss it later on. But now let's see the another question. A 60-year-old patient complained of the pain in the interphalangeal joint of the hand that get worse during the working. So worse during the working, it means that is the osteo, evening stiffness. Okay, worse during the working means that is the evening stiffness would be there. So in the evening stiffness, remember that is seen in osteoarthritis. Evening stiffness. Then after that the question number 11. So what you will see in the x-ray, we will see there is spine revealed bilateral sclerotic changes in the sacrolumbar part. So there will the sacrolumbar part will be there. The morning stiffness, we have discussed that there is a morning stiffness in the ankylosing spondylitis. The pain can be relieved during the day and after the physical exercise. So all this telling about the morning stiffness, and the morning stiffness we have discussed in the two things till now, that is the ankylosing spondylitis as well as rheumatoid arthritis. Physical examination reduce mobility in the lumbar part of the spine. So if they're talking about the spine, it means they're not talking about the rheumatoid arthritis. Increase of the muscle tonus in the lumbar area, sludge during the moving. So X-ray pattern spine relief bilateral sclerotic changes in the sacrolumbar part. So that is again like the bamboo spine or the terry appearance. So that is what test will be there positive? Most necessary, that HLA-B27 positive would be there. After that we will going to discuss about the endocarditis tomorrow. Then the next question we would be having the butterfly look friction rub. So what is that? Systemic lupus erythematosus. So but here they are asking about what is the main mechanism of the disease development. So we have discussed that there is some antibody, there would be some antibodies formation would be there. So antibodies means that is what we have the double stranded DNA antibody, ANA antibody, anti-Smith antibody, or we have one more is that is the histone antibody. Okay, is this clear? Is this clear? Okay, write it here all the antibodies again. See, if we talk about the there is a one antibody that is known as the antibodies in SLE. The antibodies in SLE, so we would be having the anti-nuclear antibody. We would be having the anti-nuclear antibody, and remember this is the best screening test for the SLE. This is the best screening test. This is the best screening test for the SLE. After that, we would be having the anti-Smith antibody. We would be having the anti-Smith antibody, and anti-Smith antibody, this is the most specific for SLE. This is the most specific for SLE, systemic lupus erythematosus. After that, we would be having the anti-double stranded DNA antibody. The anti-double stranded DNA antibody. Remember, this is anti-double stranded DNA antibody. If this is present in our body, so there will be the increased risk of nephritis, increased risk of the lupus nephritis. And if you see, there is a more anti-histone antibody. If you see the more anti-histone antibody, so this more anti-histone body will be seen, it is associated with the drug induced lupus. Okay, if we have wrote the drug induced lupus, so what are the drugs that cause the systemic lupus erythematosus? So that you have to remember, that remember the drug induced lupus, the drugs that induce the systemic lupus erythematosus. So these are the like chlorpromazine, carbamazepine, carbamazepine. Can anyone tell me what is the carbamazepine? This is the drug of the choice for the carbamazepine. It is the drug of the choice for. There is another drug hydralazine that is causing the drug induced lupus, and we would be having the isoniazid. So isoniazid, it is the anti-tuberculosis drug, anti-tubercular drugs that is used that cause the systemic lupus erythematosus. So now tell me what is the carbamazepine? It is the drug of the choice for which condition? Admitted to the hospitals, complained of the pain in the knee and the fever of 38 degrees Celsius. He is ill for 2 weeks after the acute tonsillitis. So if the question have been given the history of the acute tonsillitis, pharyngitis, so most probably there can be the, let's see what the question has been asked. Hyperemia and the swelling of the both the knee. It means there is some arthritis kind of the problem would be there, and you will see the problem in the heart as well. The heart water displaced to the left, S1 is weak, systolic murmur is present. So it means there can be the some mitral stenosis or the regurgitations can be there. The total blood count shows the HB is there, ESR is also increased, the ECG finding rhythm is regular, PQ interval is also increased. So it means it's following what? It's following the 2 1 2 criteria, either the two major, so there are no two major, but there is a one major and the two minor criteria. You can see the PQ, you can see the ESR, and also there is a temperature is also rise. So this is due to what is the causative agent, the beta hemolytic streptococcus. What is the diagnosis? The diagnosis is acute rheumatic fever, means the person having the history of the tonsillitis that will lead to the uh, that will lead to the complicated to cause the acute rheumatic fever, and it's following the Jones criteria. After that we would be having question number 17. The question number 17 is about the gout. That is the same question, that is the repeated question. Then after that we would be having the question number 18. A 34-year-old woman ill with the 3 months ago after cold exposure. She complained of the pain in her hand and knee joints. Morning stiffness is there and fever up to 38 degrees Celsius, interphalangeals, metacarpophalangeal, and the knee joints are swollen. So you can see the HOT with the reduced range of the motion. So there is a reduced range of motion. ESR is what group of the medicine would we recommend. So you have to recommend him the, like the patient has got the rheumatoid arthritis kind of the problem, the rheumatoid arthritis, and arthritis of course the inflammation. So inflammation you can give the NSAID. So that is the non-steroidal anti-inflammatory drugs like the diclofenac, aspirin you can give. You know the non-steroidal anti-inflammatory drugs, like we have the COX-1 inhibitor, we have the COX-2 inhibitor, and we would be having the COX-3 inhibitor. What are the COX? Cyclooxygenase. So COX-1 inhibitors like the diclofenac, ibuprofen, diclofenac, ibuprofen, aspirin, acetyl salicylic acid. COX-2 include the ritucoxibs, celecoxibs. Okay, COX-3 inhibitors like the our we have the paracetamol. So all these are the non-steroidal anti-inflammatory drugs that we can give to prevent the inflammation. So these are the non-steroidal anti-inflammatory drugs. Then after that we would be having the systemic scleroderma. So that we are going to discuss tomorrow. And the same question we would be having the repeated, I think. Yeah, that is the repeated. Here you can see the history of the pharyngitis. The history of the pharyngitis, the patient has the body temperature rise is there, general weakness, dyspnea during the walking, swelling and shifting pain in the articulation. It means the patient having the migratory pain, the migratory joint pain would be there. So objectively cyanosis of the lips. So pharyngitis is there, the one minor criteria is given, the one major criteria is given, and after you can see the left cardiac border deviate from the mid clavicular line by the 1 centimeter. The first outside is weakened on the apex, means there is a high chances of the mitral stenosis. So the second major criteria, auscultation revealed the systolic shuffle will be there. The systolic shuffle means mitral stenosis would be there. And the etiological factor that cause this pathological process, of course, that is the beta hemolytic streptococcus bacteria that cause the pharyngitis, that will cause the acute rheumatic fever in the patient. If you see the butterfly in the region of the nose bridge and the cheeks, so that is the systemic lupus erythematosus. After that, we would be having the 38-year-old female patient's body stiffness in the morning. Now you can see the morning stiffness is given in the question, especially in the articulation of upper and the lower limbs, that disappear 30 to 60 minutes later after the active movement. So it means improves after the movement. So it morning stiffness we have discussed in case of the rheumatoid arthritis, ankylosing spondylitis. Let's see arthritis of the metacarpophalangeal joint and the proximal phalangeal articulation. The DIP will be spared. So DIP they have not mentioned. The ESR is also increased. X-ray revealed osteoporosis or the erosion of the articular surface of the small hand and the joint. It means the small joints are involved. So everything they have mentioned in the questions. So what we have discussed about the rheumatoid arthritis. If you're feeling any problem in any questions, just let me know. If not now, then you can message me on WhatsApp also. The patient complained of the intense pain, reddening of the skin, edema in the ankle joint area. So this is the same question. That is what we have about the gout. A man complained of the periodic attack of the acute arthritis in the left tarsophalangeal joint. So left tarsophalangeal joint, we know that is the what will be the increased serum rate of the uric acid. So you see the gout, and due to gout you are seeing there is some joint problem. So that's what the arthritis, the inflammation of the joints would be there. So that is known as the gout arthritis. The infectious endocarditis we will discuss tomorrow. Tomorrow you have the loads of the things. Then we had a couple of pain and the morning stiffness. So pain or the morning stiffness would be there. That again hand joints of the temporomandibular joint. Last over the in rheumatoid arthritis the temporomandibular joints is also affected, but in the rare condition. She has the symptoms for the 2 years, the edema of the proximal interphalangeal digital joint, limited motion of the joint. What examination should be administered? You have to go for the X-ray. In X-ray you will see different type of the deformities as well. So you go for the X-ray. So what is the X-ray? X-ray means röntgenography of the hand. Then we will see the HLA-B27 positive, so the ankylosing spondylitis. Then we would be having the patient, you can see there is a patient body temperature rise up to 38 degree, pain in the small articulation, the small joints are affected. Along with that you see the face edema and erythema. You have to remember, understand this, that the face edema and the erythema, they are talking about which condition? They are talking about the butterfly rash or the malar rash. Okay, along with that there is a small joints would be affected because of the deposition of the immune complex, and you will see the RBC, HB, everything is going to decreasing. ESR is increasing. That means there are the some. This can be the these are the not specific thing that is especially for the SLE, but the remaining along with the, you have to integrate these things with the face edema and the erythema with the malar rash. That will make your diagnosis of the systemic lupus erythematosus. Then you can see there is a numbness of the first muscles, intermittent pulse. I think Raynaud's phenomena they are talking. Okay, this is the scleroderma. Raynaud's phenomena would be there. The HLA-B20 sacroiliitis. So this is the ankylosing spondylitis. And you can see that reveals the chlamydia. So what you will see in the patient we have discussed about, that is the reactive arthritis or the Retter's syndrome. Patient can't climb, can't pee, can't see. Then question number 35. The question number 35 is again the same question, that is the repeated. So what you will do? You will do the X-ray of the hands. The HLA-B20. This is the repeated question. Ankylosing spondylitis. Now you see at the exacerbation of the chronic tonsillitis. So the patient hospital with the carditis presentation. So the acute, that is the rheumatic heart disease. So what will be there? Group A beta hemolytic streptococcus, GABHS, Streptococcus pyogenes. And you can see the Gotran sign. One thing we forgot about, after that we are not okay, after that continue, we forgot about that. Let's continue about the dermatomyositis. So write down there that if you talk about the investigation, so investigation, remember what you will do. The investigation you will do here, that the gold standard investigation, remember, that is the muscles biopsy. The gold standard investigation that you will do here, that is the muscles biopsy. And what you will see here, you will see there is a CD4. You will see there will be the CD4 positive T cell would be there. CD4 positive T cell would be present. And also remember, if there will be the, of course, muscles problem would be there. So there would be the one marker would be there. What kind of the marker or the enzymes would be there? The enzyme that will be raised here, that is the CPK. CPK, that is the creatine phosphokinase. Creatine phosphokinase. So this is the marker that you have to remember. And if this is not given, then they will give in the question AST. Most probably they will give the CPK because this is the marker, the enzyme marker that would be raised in case of the dermatomyositis. Okay. And also remember the antibodies that we will see in case of the dermatomyositis, that is the anti-Jo1 antibody. The antibodies that you're going to see here, the antibodies that you're going to see, that is the anti-Jo1 antibody, that you have to remember. The anti-Jo1 antibody, and we would be having the anti-synthetase antibody. The anti-synthetase antibody. So that would be raised up. Okay. So this is what the Gotran sign is present. So this is the case of the dermatomyositis. So for making the diagnosis, you have to go for the muscles biopsy. You have to go for the muscles biopsy. What you will see in the muscles biopsy, you will see there will be the CD4 positive T cells. And there will be some perifascicular atrophy would be there, but just remember the muscles biopsy would be there. Okay, the rest question we will going to discuss tomorrow, because the most probably, and you can go for the rheumatoid arthritis, osteoarthritis. I know that you are the familiar with that, so you will do it. Okay, the SLE, they are the same question about the space, narrowing of the space, so that of course there will be the rheumatoid arthritis. Just go through all the questions by once, and we will discuss whatever the important things would be there. So tomorrow we will going to discuss about the systemic scleroderma,